Welcome to Your Health, Your Wealth. I'm excited about this episode today because I have with me today a very special guest that I am just stoked about jumping into and talking about this topic of Alzheimer's disease and related disorders. Now, just to level set us all, when we use the term dementia, this is a very broad term, and this includes Alzheimer's disease, but it also includes other cognitive disorders like Parkinson's dementia, Lewy body dementia, frontal temporal dementia, and so forth. So it's important to differentiate between the different causes because of the treatment options that, I'm excited to dive into today. But just so we know where we're going and why Alzheimer's disease and cognitive disorders is such an important topic. An estimate says that 6.9 million Americans are living with Alzheimer's disease. And by 2060, this number is expected to increase to over 13 million people. We've done a good job of treating heart disease and those type of diseases that now life expectancy is increasing. So we're seeing more and more cases of Alzheimer's and these disorders. More than 11 million Americans provide unpaid care for family members and friends with dementia, which is valued at over $350 billion with a B. And the use and cost of health care, long-term care, and hospice in 2024 is projected to reach over $360 billion. So that's why I'm excited today to talk with my guest, Dr. Schultz, about Alzheimer's disease and these new and emerging treatments. And I have with me today an industry expert who's going to break it all down for us. So super stoked about it. My guest today is a national and internationally renowned specialist in the field of cognitive disorders, what we used to call dementia. My guest today is Dr. Paul Schultz. And Dr. Schultz is a professor of neurology at McGovern Medical School and head of the UT Health Neuroscience Neurocognitive Disorders Center. I've literally known Dr. Schultz my whole neurology career. He was my program director when I got to Baylor. And since then, he's been a wonderful mentor and colleague. And I attribute a lot of what I know about seeing and treating patients with Alzheimer's disease to Dr. Schultz. He's won numerous awards, too many to mention here. He's an invited speaker at major scientific meetings all over the world. So please join me in welcoming Dr. Schultz. Thanks for being here with me today.
Thank you, Eddie. It's really special to see people you've known so many years, and where you had a little bit of impact on the training, and now to see them doing so well and doing so much. I mean, you're an expert also at this point. Yeah, and it's great to be here with you.
Well, I am excited about having you here. So let's jump right into it. Yeah. Let's start from the beginning and early identification of Alzheimer's disease and cognitive disorders. We all misplace our keys and do different things like that. But when should people go see a doctor or a specialist about their memory loss?
Yeah, it's very difficult for families to figure that out. And one of the biggest reasons is that we do all change cognitively with age. Between the age of 20 and 80, we go down about 40% in our attention span. And our attention area drives our word finding, and it drives our memory storage and memory retrieval. So, I mean, if I wasn't in the field, I would think I had dementia now because my ability to remember or find words is so bad. But as far as I can tell, I'm on the same slope as everybody who's my age, which I won't reveal there. So that makes it really difficult. The other thing that makes it really difficult is that in the community, understandably, people have the feeling, well, dementia must be the whole brain. So nothing's working right. But on the other hand, my husband still drives everywhere and he knows everything and his language is okay. People use their own vernacular words for all of that. They say, but it's really odd. He'll forget things once in a while. And his long-term memory is as good as mine. It's the short-term. It's very confusing for people to figure that out. But as you know, the secret is that new memory goes through a different part of the brain than the old memory is. So it's really confusing, but that's the exact observation we're looking for. Mm-hmm. People who forgot what they talked about yesterday with their loved ones, but they remember 5 and 10 years ago as well or better than their loved ones. So all of this makes it really confusing for people. Are we on the same line as our loved ones or not, of change over time? And how could you have just one area that's not working 100% and everything else is fine? I think those are the biggest things that delay coming in. And as you know, the really big message, I think, in dementia right now is that we have stuff that's having a significant impact, but it's very early.
Yeah.
So when your husband forgets the conversation yesterday, but is doing everything else fine, that's when we want to see you.
Absolutely. And that, to your point, I remember years ago in training, and it was kind of like, okay, at things at a certain point, we would just watch and wait. But when we start talking about these treatments, I think it's very important for people to realize and recognize that you shouldn't wait.
Right.
And we see this, and we were talking earlier about different cultural situations and different things where, grandmother or grandpa, he's just forgetful and so forth. But, there's nothing wrong with getting checked out. And I frequently see patients who come in and just say, well, I just want to get an assessment of my memory. And we do it, and a lot of times it's normal. And I say, hey, we'll watch you, but it's fine.
We'll both feel good if you're normal.
Exactly.
But if there is anything going on, this is the time to catch it when there's just a little something there, exactly. And by the way, one of the other rules of thumb I suggest to patients, if I can say it, is that compare yourself to your loved one, because you're the same age as them. So if they're forgetting the name of the movie you saw on Saturday, my wife and I, go back and forth. Neither of us can remember the name of the movie, but we're the same. Yeah. That's the key. If I'm forgetting more than her, then she knows to bring me to see myself or to see you. Yeah. And the other really big thing is your spouse knows you better than anybody. And, they'll come in and say, hey, he used to be the GPS for us. Yeah. And now he has to use the GPS. He can still find places, but that's not normal for him. Yeah. That's when we want to see you also. So it could be memory onset, as I mentioned, but it could also be the GPS isn't the GPS anymore. Or someone will come in, he's a builder, and he went to install a light switch in our house last week, and he just couldn't figure it out. Yeah. That's a red flag. He can still do everything else, but your spouse knows that that's something you could do normally, and if you're not doing it, come in and see us.
Or coworkers as well.
Coworkers, yes.
Engineer or something like that, absolutely.
Exactly.
And if you could break down some of the more common signs of cognitive decline, things that people should just be aware of to pay attention to. A lot of people don't consider or really think about word finding. So what are some of the common signs that you've seen?
Neurologists are like electrical engineers. We like diagrams, so I point to everything. But in from our ears there's two little things about the size of a finger that are involved in short-term memory. That's the most commonly affected area in early Alzheimer's. And so they don't even qualify to be called Alzheimer's, but that's the first thing that people notice. And it's not forgetting where your keys are. If that was the case, then my wife and I would both already be well into...
Ain't that the truth? Me too.
Right. It's when you forget something that you shouldn't, like the conversation yesterday, or, people will go on a trip to Europe for 2 weeks, and a month later, they don't seem to remember having gone on it. They remember stuff from 5 years ago, the kids' weddings and all that. That's the kind of memory that gets us worried. The forgetfulness of reduced attention, that's what we see with aging. Yeah. Forgetful is what cues us into the part of the brain being involved that is affected in early Alzheimer's.
Absolutely.
And then as you say on the side over here, I'm pointing because in most right-handers' language is on the left. Nouns and verbs are here, adjectives, adverbs, prepositions here. If a person is developing a real problem with nouns and verbs, that means it's starting right there. Everything else can be fine. Come and see us. Yeah. If it's just the adjectives, adverbs, prepositions, so they're down to, door open, not may you please open the door, then that's the time to see us also. And then the visual spatial, that's another part of the brain, and that's a very common one. That's second most common, actually, to memory loss. So coming up to the corner and not being sure if they should go right or left to go home, that would be a very common presenting symptom.
Getting lost while driving, absolutely. Now, I started off by talking about this term of dementia, and it's a term I don't really like to use a lot. It's because it's so broad and people don't really understand. But cognitive abnormalities is a whole family of things. And I've seen patients who have been misdiagnosed for years.
Yeah.
And some have come in with reversible causes like normal pressure hydrocephalus, and they've been misdiagnosed with Alzheimer's for 5+ years. It's something that's potentially treatable. So why is it important to really dig in, and do those studies to really figure out what type of dementia, and I'm putting that in quotation marks, or cognitive abnormality someone has?
Yeah, no, really good question. And as you say, number one, if you pick up normal pressure hydrocephalus, every month I pick up somebody with low B12. I mean, really low B12. That's actually causing their symptoms. Thyroid disease is very common. So all the reversible stuff you want to pick up, because that's a lost opportunity if we don't identify that. And secondly, if it turns out to be plaques developing in the brain causing Alzheimer's pathology, they don't qualify yet as having Alzheimer's disease, but they have Alzheimer's pathology, we want to detect that early, because we now have drugs that remove the plaques from the brain. We can have someone with plaques everywhere, and 6, 12, 18 months later, we do a repeat PET scan, and there's no plaques there. And that has a significant impact, as you know, on how people do. So yes, we want to see people early to rule out reversible stuff, and then also because that's when the Alzheimer's stuff is really working.
And as far as the not only the treatment course, but how people do it is different between some of these conditions like frontotemporal dementia.
Totally different, yes. And there's all kinds of other reasons to catch dementia generally early, like FTD. People generally, like 90% when you do studies of it, want to know what's going on, even if it's one of the dementias we haven't yet figured out how to treat, because they can plan their life. Okay, that's going to happen, so I need to take care of that will now that I never took care of, or I need to take care of my medical power of attorney. I need to go visit the grandkids more. I need to go on that world trip. I need to do that now because, something's going to change down the road. So even knowledge is power for people. So that's another reason to figure out what's going on, even if it's an area where we don't yet have a major treatment for.
Yeah, that's therapy. To put a name on it, to for some of these patients, just say, okay, we've diagnosed you.
Yeah.
And so what I'm hearing is an important point is, number one, it's important to go in and get evaluated, because as you mentioned, there are some things that are reversible, treatable, like B12 deficiency or not Lewy body, but normal pressure hydrocephalus.
Yeah.
And on top of that, even with Alzheimer's disease, we have newer treatments that the earlier that we can diagnose patients, we have treatments that we can treat them with. Exactly.
All important reasons to see us. And as you say, education is critical. Education is power, knowledge is power.
Yeah. So let's talk about specifically the diagnosis of Alzheimer's disease. When we first met, when I was straight out of internship and coming down, I reflect on those days and I think about, and I remember, you teach me this, is that, look, to definitively diagnose Alzheimer's disease is at autopsy. You could only say someone had probable or possible Alzheimer's disease. And then you just, treated them. We had, one medication that we would start initially, the Deficiency, and then later on as it advanced, you gave them Namenda. And that was pretty much it. And aside from that, you gave them some life-changing or lifestyle modifications, exercise, which, I've talked extensively about as far as exercise, diet changes. But now we have much stronger tools to be able to differentiate and to diagnose. And that's like serum biomarkers, imaging biomarkers. So tell me how this landscape has changed and what you've seen.
Oh my God. 2011, June of 2011, that was the anchor point in my mind.
Okay.
Because that was the day that the FDA approved the first amyloid PET scan.
Okay.
That was a shocker. We had been using them as in trials, and so I had familiarity with them, and we knew they were valuable, but we weren't using them diagnostically as much as did they qualify for this trial. This was the first time in human history where we were able to say during life that someone has Alzheimer's pathology or Alzheimer's disease. So up till then, we would say, well, if you had the right clinical features and we ruled out this stuff, at autopsy, if we found frequent neuritic plaques, we would say that was Alzheimer's. The clinical was during life, the plaques postmortem, which was very late.
Yeah.
So now we had a tool that would see frequent neuritic plaques in a person like you and I. Mm-hmm. In fact, we even see it in people with no symptoms now. That was a shocker. And it turned out we went back then in the early 2010s and started imaging people that we had in trials all around the country. And it turned out in different studies between 12 and 30% of people in the Alzheimer's trials did not have plaques that we could see.
Interesting.
So, one of the things that I guess the message I'm going to get to here is that before then, probably a lot of trials were negative because there were a lot of people mixed in who didn't have Alzheimer's.
Yeah.
So that 2011 June was critical for now. Every trial after that, we know 100%, 99.5%, we know that they have Alzheimer's. If you have those plaques and the right features, it's really accurate, is another important message. In the other direction, if it's negative, that's really accurate too. And so if it's valuable to families to know one way or the other. And now the drugs that we have, the new ones that we'll mention, they're specifically to get rid of plaques from the brain.
Yep.
So obviously, you got to know for sure if someone's got plaques, because you don't want to give treatment to someone who doesn't have them, and you want to catch people early who do have the plaques. So the amyloid PET scans have been critical. And the second part of your question is blood biomarkers. That's a really complicated story, but a valuable one. And if I could say just a few words.
Sure, absolutely.
What's happening in the real world is that you go to your internist and you say, well, I'm having some memory problems, and he asks the wife about it, and she says, yeah, sure enough, Paul's a little forgetful. So what's he going to do about that? Well, he can't do a $6,000, $5,000 amyloid PET scan on everybody.
Yeah.
So what's happening is they're doing blood-based biomarkers out in the community, which is great. Mm-hmm. The amyloid in the brain and then another protein called tau in the brain leak into the blood, and some of the assays now are pretty darn good at detecting that. Absolutely. And so he can say, well, let's get this blood test, and if it's positive, I'll send you to see Dr. Patton, and he can work you up the rest of the way and give you the treatment for it. Mm-hmm. And now the challenge is that they're about 90% positive predictive value and 90% negative predictive value. What I mean by that is there are still some people who have early Alzheimer's that won't be detected. Mm-hmm. The majority will be, and that's good. So those people can come and see you and I. If the internist or you and your family have the strong feeling they really look like what I've read about with Alzheimer's or heard about or seen in this podcast, and they're progressing, go and see the neurologist then and get checked out. Those ones we still want to do amyloid PET scans on. But the good news is that the blood test has ruled out 90% of people that doesn't need any of that stuff. So we don't have to put them through the testing and the radiation and all that kind of stuff. So they've been a really good adjuvant to the early diagnosis of Alzheimer's. By that I mean the blood tests have been. Yeah.
And it's also important to note that patients sometimes get frustrated because every time they come in, I'm doing an MMSE or a MOCA, but this is a memory issue.
Yeah.
So I could check your strength all day, but these tools that we use in clinic, like the mini mental status exam or the Montreal Cognitive Assessment Test, that's a way of really following how you're doing, how you're progressing the treatment, and so forth.
The other thing that, as you know, that's kind of probably not common knowledge is that the amyloid plaques build up for 10 to 20 years before someone comes in with a symptom. Yeah. And by building up, I mean there's enough we can see them on a PET scan. So obviously they started before that because you got to have a lot of them to show up on the PET scan. So for the person in the community, you don't necessarily want to get an amyloid PET scan unless you're certain they have cognitive changes.
Absolutely.
So the threshold is cognitive change, and that's where the MMSE and the MOCA, which annoys people, is the gold standard. You got to have a change on that, and then if you have amyloid in the brain, you're perfect for treatment. But if you're 10 years early, we don't know yet whether this stuff helps or not, so we can't treat you at that time.
Yeah.
So it's annoying, but yes, you and I have to do those quizzes. Because if you get a 30 out of 30, well, whether there's amyloid or not, we're not going to do anything.
And that brings me back to the whole thing about lifestyle change, exercise, and everything else, because the point that you made that if you look back, by the time someone has symptoms, the process has been going on for a number of years.
Yeah.
So if we have these conversations early with patients about risk factor modification, exercise, the types of things that you can do in your lifestyle to prevent cognitive loss, and hopefully we can see slowing the progression even before you get to this stage.
Yeah, reduce the risk of getting it. And then if someone has MCI, early Alzheimer's, all of those lifestyle factors slow the progression. There's a lot of studies that we and others have done showing that lifestyle modifications are very valuable. In general, the studies have shown a 20 to 80% risk reduction. So most of us in the field say, well, looking at all of them, it's about 50% on average. That's huge. I mean, if we can delay or reduce someone's risk of getting Alzheimer's by 50%, that's an unbelievable number of people. I mean, you were quoting 7 million Americans now have Alzheimer's. If we reduce the risk of getting it, and then for those 7 million slow it just by lifestyle modifications, that's inexpensive and wonderful. Now, you and I know it's tough to get someone to start exercising.
Oh, yeah. Trust me, I know that.
It's tough to exercise ourselves, much less tell someone else, you really got to start doing this.
Yeah.
And then you got to take a statin. You got to take a blood pressure pill. No one likes that stuff. But all of those cardiovascular risk factors that people know about are also risk factors for Alzheimer's. So by lifestyle, we include taking care of other medical conditions, vascular risk factors, and physical and mental exercise, and the combination of all that significantly reduces the risk.
And this population is usually older, Medicare age.
Yeah.
Have you noticed any economic issues with getting the testing that patients need and so forth?
Yeah, no, honestly, putting politics aside, we're blessed with Medicare. Because if you're over 65 and have Medicare, they never argue with us about getting testing. They have criteria. So all I do is go online and say, yes, we've done the MRI and it was negative. Yes, we did the thyroid, we did the B12, we did a cognitive test and it looks like it. And then it says, okay, fine, go ahead and get the amyloid PET scan. The challenge is the non-Medicare coverage. The Advantage plans and private insurance will argue with us. We've pretty much gotten everybody through now. We've learned how to deal with that. But I tell patients if they have Medicare, you'll get this scan in a week and you'll get the treatment in the week after that. If they have different insurance, it'll be a month before you get the scan and 2 or 3 months of us arguing on the phone with your insurance company to get it covered. You will. Yeah. We will persist with you. We will be your advocate. But it's going to be a few months.
Yeah.
So there is resistance by non-Medicare providers, payers.
And so now we've got these patients worked up. We've got them diagnosed. So let's talk about advancements in treatments. The past 3 years have been great, and I'm optimistic about the future. So, I mean, you've been in this arena for a long time, and so tell me. Give me your outlook as far as the landscape, and tell us about these new treatments for Alzheimer's.
Oh my God! As you said, Eddie, I don't want to reveal my exact age, but I've been doing this for many decades. And honestly, it was really frustrating and depressing to tell someone they had MCI, because I knew 8 years from now, on average, that they were going to have progressed to the point where they didn't know the neurologist or their loved ones, And now the landscape is so different in clinic, and everybody I see has some form of dementia. So, you and I are used to seeing people progress. There's variability, but they progress at a certain rate. The whole clinic now has changed the rate.
Wow.
The whole clinic, everybody I see now is different than in the distant past, like more than 2 years ago. It's changed that incredibly in the last 2 years. Since lecanemab got approved 20 months ago, and donanemab got approved 8 months ago, the two of them are just doing I hate to say gangbusters, but that's what it is in the vernacular.
Sure.
They're having a dramatic effect. You know, it used to be that by the time I'd known a patient for a year, they would forget who I was. They would forget having been to clinic before. They wouldn't know why they were coming in for a study medication, and it was kind of tough you feel bad about talking someone into something if they don't know that they've got a disease and why they're there and why you're putting an IV in their arm.
Yeah.
Now it's totally different. Now I had a guy a few weeks ago, Dr. Schultz, come in here. Come in here. He was getting an infusion. I said, yeah, what's up, Mr. So-and-so? Sit down. I got to ask you a question. I sat down. Yeah, I've known him 4 years.
Okay.
So that's actually the point of the story. He says, how am I doing? I said, sir, I have never had a patient who knew who I was after 4 years.
Exactly.
I've never had one know why they were coming to clinic. Mm-hmm. I've never had one know the nurse because you see her once a month or once every other week. I said, you know, I realize that you have to look at it from your point of view, but from my point of view, this is a miracle.
Absolutely.
It's a miracle that you know all of this, and all you are is forgetful. Mm-hmm. The rest of everything you're doing fine. We kind of stopped you. Not everybody stops, I can't say that, but it slows them down. But in his case, he's one of the ones that 4 years later, he's still forgetful, but that's it.
Yeah.
And we really see by the change in the curve, for some people, it slows progression 20 or 30%. That's better than nothing. Mm-hmm. For other people who are earlier, we have plots showing 60% slowing. And then with both drugs, we have people who have been stable. It's not a high percentage, but we have people that have stayed stable for a long time. By that, I mean at least 1.5, 2.5, 3.5 years. So it's changed the landscape, and it's made my whole outlook better too, because I hate to see my patients progressing.
Yeah.
And getting forgetful and going through all the stages, and I hate to see the loved ones suffering as they can see their spouse or their dad changing every month a bit, and they can see the brain getting smaller in the real world. And now it happens. Sometimes we have bad luck, but for the ones we catch early, you can tell that it's slowing things down a lot. And the next step is that we still have at UT there, we still have more than a dozen treatment trials. Oh, wow. So we're looking to say, okay, this is great. We got something that slows things down, but we want to stop this thing sometime. I don't know if it'll be my lifetime or not. I hope to God it is, but we'll see. But we're doing other things that we anticipate adding to donanemab and lecanemab. And so in other words, those are both anti-amyloid, but we also, tau is a big part of the disease. Mm-hmm. So we have 4 trials looking at getting rid of tau to see if that helps and adds to it. And then the next step is called inflammation. That's how the cells in the brain are actually killed by the disease going on. That's how we lose them. And we have 4 trials going on that are anti-inflammatory. So my fantasy is 5, 10, 15 years from now, someone will come in, we'll give them anti-amyloid, mm-hmm. anti-tau, anti-inflammation, and God willing, we'll be able to stop this disease someday.
So there'll be some type of combination of all those factors.
Yeah, it's just like you take it for granted with cancer. You get one drug, and then there's often a second and a third one, if needed. Or for blood pressure, some people respond to one med, some take 2 or 3.
Yeah.
It depends on, you individualize it depending on what you see with them. I anticipate we'll do an amyloid scan, a tau scan, which we're doing for research purposes, and we're doing inflammation PET scans for research. So I know people have got all 3 of those.
Yeah.
And I anticipate doing those and saying, well, you've got this and this, so we're going to give you these 2 meds. You've got this and this, so we're going to give you those 2 meds, and we're going to have an impact on how you do.
And I don't think that people really appreciate how complex this disease is. They see the brain shrinking and they think, oh, my brain is just shrinking.
Yeah.
That's a part of it. But there are a number of things going into play from the buildup of beta amyloid. You have tau deposition and there's inflammation, all a part of the process.
Vascular changes, free radicals being released. You're absolutely right. It's a very complicated disease. But it does start with amyloid as far as we can tell. And so cutting off the head there, I think, is why we've had an impact on how people do. But once that's been there a while, all of those other steps are set in motion. Mm-hmm. And so the challenge for us is to identify people early enough to keep them from really getting set in motion, so to speak. Mm-hmm. And I think that's going to be the answer to preventing the disease. Or they've been set in motion at a low level, and we're going to nip it in the bud for them too. Okay. We'll give you the anti-amyloid, but we'll also give you the anti-tau or the anti-inflammation or the one that protects the vascular system, or the one that gets rid of the oxidant products that are lethal to neurons also.
So we have this patient, we've identified them as a candidate, we've got them going. These medications do have potential side effects. So how do you counsel about those side effects and what people need to look out for?
Yeah, as you know, Eddie, it takes about 45 minutes just to do the skeleton of side effects, and then I give a handout, and then we often have to have another conversation. It's complicated, but there's basically 3 side effects I tell people about, and it's important to know that we've been seeing them in studies of these medicines, but also the 20 anti-amyloid antibodies we had before that didn't turn out, but we learned about the side effects. So the point I'm getting at is that we've now learned to watch for those 3. We've learned to also detect them oftentimes before the person has the symptom. And that has been the real secret to preventing long-term consequences for patients. So the 3 of them, if I could say, one is, like when you get a blood transfusion, if it doesn't match you exactly, you get a mild allergic response. Same with these guys. We're giving people antibodies against amyloid plaques, and about 9 to 25%, depending on the drug, of people will have their immune system recognize the antibody as not being made by them.
Yeah.
We call that an infusion reaction, and that occurs right away when we give the drug. It's not life-threatening or anything, except maybe a fraction of a percent can have anaphylaxis, but I've never seen that, thank God. But a lot of people, they'll be sitting there and they feel like they got the mild flu. I'm getting a little headache, get a little chills. We just give them acetaminophen, diphenhydramine, which is Benadryl, and that usually takes care of it, sometimes a shot of steroids. So infusion reactions, very common, very easy to manage. We have EpiPens in case, God forbid, someone ever actually has anaphylaxis. Any medicine can have anaphylaxis. It's not specific to these. But I've never had to use one after 20 years of antibodies. That's the first one. That's why you're giving it. And then 2 to 4 weeks later, there's 2 things that can go on in the brain. One is swelling and one is microhemorrhages. They sound terrible. And, of course, we take them very seriously. But we've learned to prevent them through 10 different things we do. Don't worry, I won't name all 10 of them and put you to sleep. But we've learned to who to put on the drugs. So we have about a half a dozen things we do where we say, okay, you're in the 5% that really shouldn't get the drug because we don't want to put you at risk. And then while we're giving the treatments, we monitor people, and there's another 3 or 4 things that we pick up early and say, okay, we're going to stop the treatment either till this goes away, or there's enough of it that even when it goes away, we're not going to restart again. And the point is that by doing all of those 10 things, we've really made these drugs a lot safer. We do see the stuff. We take it seriously. We always look for it. We do lots of MRIs to pick up this stuff. Nowadays, though, 80% of the time we pick up the swelling or microhemorrhages, 80% of the time before there's a symptom. So it dramatically, and even in the 20% with symptoms, it's early. So we say, hey, you've got the swelling. We're just going to hold the infusions, and we'll do another MRI in a couple months. And if the swelling is gone, we'll start up again.
And that's why patients have to be on these MRI protocols and get these images, particularly in that first, 4 to 6 months of treatment.
Exactly. Almost all of the side effects are in the first 4 to 6 months, as you alluded to. Once we're past that, we don't have to worry so much. It's very rare. But that's when we see the side effects. So that's when we've learned to do all the imaging to pick them up again most of the time before someone has a symptom. Exactly.
And you mentioned how much of an impact that these new anti-amyloid therapies are having on, and I don't want people to have so much fear that we're not treating the people, because like you and the patients that I have on treatment, I've seen pretty good benefits from using these treatments.
Yeah, really good point. I mean, someone from the FDA said if aspirin was invented nowadays, it wouldn't be approved. Because it has side effects. People do have bleeds from it, ulcers, etc.
Absolutely.
Every medicine has side effects. The big thing, as you're alluding to, is to learn how to use the drug safely, as safe as possible, and to be very vigilant about looking for side effects, etc. But as long as you do that, 99.9% of my patients sail through. Most of the time to them, it's a surprise when I call and say, hey, you're having this inflammation I talked about. I can't be having that. I'm fine. Yes, that's why we're picking it up. That's why we did the MRI now. We picked it up. It's only small. We're going to stop and wait, So, focusing on safety is why we now can use aspirin.
Yeah.
And it is why we can use these two anti-amyloid drugs, because we've spent a lot of time thinking about the safety of them as well as proving that they actually have a benefit efficacy-wise.
And with all of these IV therapies, of course, they're expensive.
Yeah.
The cost of medications is high on the public's mind nowadays, and figuring that out. Are you seeing any issues with patients being able to get on these treatments? Any financial limitations? Yeah,
that's a really important question, because it does no good to have a great drug if no one could afford it. They are expensive. I mean, they're not as expensive as a lot of chemotherapy agents. They're not as expensive as a lot of multiple sclerosis and myasthenia, but they are expensive. There's no doubt about that. Fortunately, if you have Medicare, for the most part, I don't see people paying much out of pocket. It depends on whatever your plan is, what your deductible is, and that kind of stuff. But we have not had anybody we couldn't get on the drugs. Again, with Medicare, it's pretty straightforward because there's criteria and you go for that. It's the other plans that are more challenging. But there are, I would say the biggest access problem, financial is a big consideration, but I would say the biggest access problem is knowing about it.
Okay.
And the majority of Houstonians, especially from underrepresented groups, are not hearing about it. So they don't know to call you and I and say, I insist on being seen and getting on these new meds.
Yeah.
That's and there's also cultural factors. I mean, 40% of Houston is Hispanic and 12% African American. There's cultural beliefs in those communities that we have to address. Mm-hmm. And get their buy-in on that. Sometimes I have to talk to their minister.
Yep.
They trust the minister more than me, which they should.
Yeah.
He has divine intervention. I don't. I just use God's gifts.
Absolutely.
So those are all things that are real challenges. I was, just yesterday, one of my medical students was collating how many Anglos, Hispanics, African Americans are coming to our clinic versus the community, and the underrepresented are not as well represented, pretty well. We do a lot of outreach, but it turned out the males were way underrepresented in the underrepresented communities.
Yeah.
So it's as though the men are saying, I'll bring you into the doctor, the wife, but they're saying, no way am I going in there. That's really critical, because if you don't get on these meds early, that's a lost opportunity.
Absolutely.
I feel terrible when I see someone who has progressed to the point, well, now I can't help. So getting African American and Hispanic men in to see us, along with their wives, is really critical for access. Yeah. And if they're over 65, sometimes we help them apply for Medicare. Mm-hmm. Yeah, you got to get on this, and then we can give it to you, It's a little delay, but we'll get you on it and get going.
So people should not be afraid to go in and seek help about this, because the limitations around costs and so forth, as you mentioned, we can work around that. We're working with insurance companies, working with Medicare to make sure that the people who need and who would be approved for these medications get on.
Yeah, the big message is that I did this calculation earlier this week. 99.998% of people who should be on the drug in Texas are not on it.
Wow.
So, we've got a couple thousand people now on these meds out of the 250,000 Texans who are early enough in Alzheimer's to qualify for it.
Yeah.
And if you look at the United States as a whole, like you said, there's 7 million people with Alzheimer's, maybe 4 million are early enough to qualify. And I think for lecanemab, there's 12,000 people in the world on it.
Oh, wow.
It's a fraction of a percent.
It's a fraction of a percent, yeah.
And for Kisunla, which was approved later, it's even lower than that. Yeah, so the biggest barrier is getting people in.
Yeah.
And if you come in and we decide with you that turns out you're okay, it's just normal age-related changes, Dr. Patton and you will celebrate. Say, hey, you're good. You don't need this.
See you back in 6 months to a year.
Yeah. But if you need it, we want to catch you early, because that's when it works.
Yeah. So, again, you've been in this field. We've got the new medications. What are you optimistic about the future when it comes to treatment of Alzheimer's and related disorders?
Yeah, I'm actually particularly optimistic down the road for two reasons. One is we are doing other trials in people with early Alzheimer's. But honestly, and I hope they all come out positive, of course, but the real secret, I believe, or the way we're going to prevent this disease is that we do have that 10 to 20 year period where people have plaques we can see in the brain. Mm-hmm. And the question is, if we start giving them anti-plaque treatment before they have a symptom, does that do even better at reducing the risk of the disease or delaying the onset? And that's where I'm putting a lot of my hope right now. My group has 4 trials of people with no symptoms.
Oh, wow.
So we have hundreds of people coming to clinic with no symptoms that are getting the same treatment as the people in the next chairs who have symptoms. And we're praying to God that when the blind is broken after a while, that we have an outcome that says, again, because there's a whole set of things set in motion by the amyloid, when someone has symptoms, we're really over 20 years into the disease.
Yeah.
And so the thought is if we catch them at 10 years and get rid of the amyloid, maybe the downstream stuff never gets set in motion.
Wow, so that is pretty exciting, that if we can catch these pre-symptomatic patients, meaning maybe they have those genetic predispositions and they're starting to build up amyloid. That still doesn't mean that they're going to develop Alzheimer's, but they may have a higher chance.
Exactly.
But can we do something now to curb those numbers that by 2060 and along the line, we're starting to see less cases?
That's exactly my fantasy. Right now, what happens as a practical matter is, I'm sitting there talking to a woman or a man who has early Alzheimer's. They're 75, 80 years old. And the kids are sitting with them, and they're 55, 60, and I tell them, well, you've got this gene that was a risk factor, and it's probably why you're coming here now with the disease. And the kids are going, hey, could I have that?
Yeah.
And that's where I get all the patients for our pre-symptomatic trials.
Yeah.
It's like heart disease in my family. My dad has heart disease, my brother. I go to see the cardiologist every year. I do everything he tells me to do. I am fearful.
Good compliant patient. That's
I'm
good.
very compliant. I am fearful of heart disease. Well, they're fearful, understandably, of Alzheimer's disease and very motivated. And so we have trials of anti-amyloid, anti-tau, and anti-inflammation in people with no symptoms.
Wow.
Yeah. And as I say, my prayer is that 5, 10, 15 years from now, we're able to show that if they're pre-symptomatic, we can either head it off or significantly delay the onset.
So if you if there are people out there watching and they're curious about things, they're interested in these trials, give them your website or where can they go to get more information?
Thank you. Yeah, we're at UT, and Paul Schultz is my name. You can Google me and find our office number. If it's for research, we'll shunt you to our research coordinators. If it's for early symptoms, we'll send you to one of our clinicians to get the diagnostic workup and the treatment and all that. Yeah, we're very grateful to people who volunteer because that's how we've managed to move the ball down the field. It's people who, with early Alzheimer's or pre-Alzheimer's now, who are willing to volunteer and say, hey, you know what, I want it to be better for the next generation.
Yeah.
And they are the ones who have allowed us to find 2 medicines now that are having a significant impact on people's lives.
Yeah. Well, Paul, this has been great. I share your enthusiasm, and I've loved working with you over the years and look forward to working closer with you in making sure that we're addressing Alzheimer's disease, we're getting patients identified and getting them treated.
Eddie, always great to work with you. I hope we have many more decades together.
Absolutely, my friend. Thank you so much.
Loved it. Thank you.
I hope you've enjoyed this episode of Your Health, Your Wealth. Please subscribe and share. And we look forward to talking with you later in future editions.